Navina, we can start.
Good evening, all. Welcome to the Higgs Journal Club for the month of August. This month, we'll be speaking about restrictive red blood cell transfusion strategy for critically injured patients, Restric Trial. A warm welcome to our mentor, Dr. Jose Chaco, sir, who is a pioneer in the critical care, and also to our moderator, our dear sir, Dr. Gansham, sir. To take us through this trial, we have Dr. Bharat, critical care consultant from Citizens Hospital, Hyderabad. Bharat.
Thank you. Good evening, everyone. I first would like to thank Jose Chaco for his time and the Higgs platform for giving me this opportunity. So we'll be discussing today on Restric Trial, which is the restrictive red blood cell transfusion strategy for critically injured patients, which is a cluster randomized crossover non-inferiority multi-center trial of restrictive transfusion in trauma, which is published in July 2023. With the primary author is the Mineji Hayakawa from Tohoku University of Japan. So the research question here is to examine whether a restrictive transfusion strategy was clinically non-inferior to a liberal transfusion strategy during the acute post-injury phase. Coming to the clinical question, they have divided the patient group into two hemoglobin target ranges of 7 to 9 gram per deciliter into one group and compared with the 10 to 12 gram per deciliter group. The background, this Restric trial derives its background from the famous TRIC study, which is published in 1999 in New England Journal of Medicine, which is again a multi-center randomized control trial regarding the transfusion requirements in patients admitted to critical care. And one more guideline, which is published in 2019 from the European Society, the European Guideline on Management of Major Bleeding and Coagulopathy Following Trauma in their 5th edition. They recommend that the transfusion target hemoglobin of 7 to 9 gram per deciliter with the background support. Again, they derive the same background of TRIC trial. However, they have reiterated that the subgroup analysis from the TRIC trial in trauma patients has been projected into the guidelines and also the background of this particular study. However, it also says that there are very few transfusions in the restrictive group when compared to the liberal group in the TRIC trial as well. But the guideline also emphasized that the TRIC study is neither designed nor powered to answer the questions with precision, especially in trauma patients. So the study design of our Restric trial is a cluster randomized, crossover, non-inferiority, and a multi-center trial, and the duration being from May 2019 to October 2021, close to 2.5 years. So the study design is, we have divided our study groups into two units based upon the transfusion threshold of 7 to 9 gram per deciliter and 10 to 12 gram per deciliter. Here, the study is a cluster randomized trial, which means the individual unit of randomization is a cluster, that is a hospital. The total hospitals are 22. 11 hospitals are divided into group of restrictive transfusion strategy and 11 hospitals into liberal transfusion strategy. And then they have been studied on each respective protocol for about a year with a washout period of 1 month where the hospitals have been crossed over to the other arms. That is, the hospitals which have been in the liberal strategy group are crossed over to restrictive transfusion and vice versa. And again, the study is repeated in the sentence of 1 year. So the study population were, the inclusion criteria is any patient with age of more than 20 years old who has met with the trauma and has one of the following complications. These complications were decided by the physician. The complications being the patient having severe bleeding, which is leading to circulatory shock, or suspected severe bleeding, or potential for severe bleeding if requires any surgery. The exclusion criteria being a patient met with the cardiac arrest before or after arrival, on arrival to the ER, transfer from another hospital, physician decision to withdraw the active treatment at initial assessment, burns with more than 15% of body surface area or related complications, pregnancy, chronic anemia where the baseline hemoglobin available previously before the trauma being less than 7 grams per deciliter, and objection to blood transfusions like Jehovah's Witness. The outcomes they studied were, the primary outcome is 28-day survival after arrival at the emergency, and the secondary outcomes being time to death during the first 28 days if the patient has expired within 28 days, and the cumulative transfusion requirement of all the products like RBC, fresh frozen plasma, platelet volumes transfused on day 1, day 7, and day 28, ventilator, catecholamine, and ICU-free days in first 28 days, and organ failure during the first 7 days based upon the SOFA scoring, and complications like DVT, pulmonary embolism, cerebral or myocardial infarction, bowel ischemia, and any transfusion-associated lung injury and sepsis during the first 28 days. And they've also measured the Glasgow Outcome Scale scores at the hospital discharge. The sample size is being calculated based on the previous retrospective observational studies, which were again multi-center studies. And they assumed a 25% mortality rate at 28 days after arrival at emergency department in patients who are exposed to a liberal transfusion strategy. And they have taken the interclass and interperiod correlation coefficients at 0.05, and non-inferiority margin, they were set at 3%. So in our trial, they calculated a sample size of 170 patients for each strategy group to reach a power of 80% and a one-sided alpha of 2.5%. The statistical methods applied in the study are, all the continuous variables were described as medians with interquartile ranges and were studied using Wilcox and ransom test, and category variables like numbers and percentages using chi-square test or Fisher's exact test. And analysis was done using the mixed model analysis, where there are fixed effect factors like intervention and period are taken as fixed effect factors, and random effect factors like site and interaction between the site and the period of the study. And null hypothesis proposed is the difference should be less than minus 0.03, where the P0 and P1 are described as 28-day survival in liberal and restrictive groups respectively. Coming to the analysis, the primary analysis is done based on intention to treat analysis using logistic regression also. And the per protocol analysis is used for sensitivity analysis. The secondary outcomes were studied using Kaplan-Meier curves, hazards ratios using the log rank test. Subgroup analysis is with the study of effect of our intervention on age, sex, and presence or absence of head trauma, and performance of definitive surgery within 6 hours of arrival at ED. So coming to the results, they have done both the analysis, that is intention to treat and per protocol. So based on intention to treat, there are 216 and 195 patients in restrictive and liberal transfusion group respectively. When they come to the per protocol analysis, because of 6 patients being excluded from the restrictive group has come down to 210, and 1 patient excluded from liberal group. So the liberal group has come to 194 when they considered the per protocol analysis. So coming to the hemoglobin levels that were measured during the first 7 days after arrival to the emergency department, the dark black is the liberal strategy and gray is the restrictive strategy. If you see the liberal strategy, the hemoglobin levels are always almost maintained above the target, that is 10 to 11. And the same is the condition with the restrictive strategy as well, which is always between 7 to 9. And the cumulative transfusion volumes during the first 28 days after arrival in ED, there is no much difference in the cumulative transfusion volume if we see at the first 6 hours of the study period. But once we see from once the time crosses 12 hours, we can find out a significant difference in the cumulative transfusion volume requirement in both the groups. Again, the white one is the restrictive strategy and the gray one is the liberal strategy. So we can clearly identify the difference in the transfusion volumes starting from 12 hours. So coming to the proportion of patients without RBC transfusion during our study period, again, the restrictive group scores much more when compared to the liberal group. So the proportion of patients without RBC transfusion are always higher in the restrictive group when compared to the liberal group. And the survival, complications, and event-free days were actually not significant. There is no significant difference in between both the groups, that is the restrictive and liberal, when we see at the survival rate, complications at even-free days. So when we see the Kaplan-Meier survival curves at 28 days, we cannot find a significant difference in between both the groups. And when we see the adjusted odds ratio of survival at 28 days, neither of the parameters are actually significant and favoring either the liberal or the restrictive strategy. So all the parameters are touching the line of no difference. So when we see the per protocol analysis, again, there is no significant difference in the rate of complications in both the groups. And when we see the Glasgow outcome scale scores, again, there is no significant difference in between both the groups. That is either liberal or restrictive groups. So the author's conclusion was the application of restrictive RBC transfusion strategy for patients with severe trauma at risk of active bleeding resulted in the smaller transfusion volumes and lower hemoglobin levels compared with those of the patients with liberal transfusion strategy group. And the 28-day survival rate, survival time, complication rate, and number of event-free days were not significantly different in between both the groups. However, the non-inferiority of the restrictive RBC transfusion strategy to liberal RBC transfusion strategy was again not statistically confirmed in terms of the primary outcome, that is 28-day survival rate. So coming to the strengths and weakness of the study, the strengths being, one is the relevant question, which we see in every day for all the trauma patients. We look for a proper trigger to initiate the transfusion. And the statistical methods they used were like using both intention to analysis and per protocol analysis and describing the sensitivity analysis was good. Coming to the weakness, the background, they took it from the TRICS study. Again, the European guidelines as well, they again based their background on the TRICS study, which actually was not supposed to study the trauma group. But however, they did a post hoc analysis. And even the patients with active bleeding was actually excluded in the TRICS study. And coming to sample size, the author mentions himself that there was a gross error in calculation of the sample size during the study, which was actually noted at the end of the study, which again was a weakness. And non-blinding, because the intervention will obviously be understood by the treating physician, so it could not be completely blinded. And here the hemoglobin target was defined everywhere, but not the threshold, like the group, restrictive group being 7 to 9 grams per deciliter and the liberal group being 10 to 12 grams per deciliter. So if you ask me that whether this will change my practice at this point of time, I would say no. Thank you.
Thank you, Dr. Bharat. Any closing summary that you want to say in a small nutshell about this trial?
Yes. So the Restric Trial, actually, they aimed at addressing the very apt question of being either it should be on the restrictive side or liberal side, especially in patients with trauma presenting to emergency department. However, because of the background being chosen from a trial which is not actually intended to study the trauma patients or the patients who have actually active bleeding, that is the main drawback. And the other thing is the size of the sample, which is actually not adequate to find out the non-inferiority. However, they have conducted the trial well with the statistic methods being applied and all, but the conclusion is not appropriate with the studied sample size. So I feel that a better trial with a large sample size would address the question.
Thank you. Ghanshyam sir, what is your strategy and how do you take this trial in your practice?
I think one of the main indications or the background for this trial was, see, we have, there is always this, thought and belief that in critically ill patients, if we can, increase the oxygen delivery if you go back to the basics and look at the oxygen delivery formula, you have hemoglobin playing a major part in that. So that has always been one of the strategies wherein it was believed that if you can keep the hemoglobin at a higher level, then maybe your oxygen delivery would be better. And ultimately, we are looking at ensuring that the oxygen delivery to the tissues is good. I think we have trials which have been done in different subsets of critically ill patients, but we did not have, a hemoglobin targeting study exclusively for trauma patients. Whatever guidelines were recommended were based on the subgroup analysis or post-hoc analysis from the TRIC trial. So I think that was the background where they attempted to do a randomized control trial to look at a liberal versus restrictive strategy. I think that's the main background.
So do you take a target, sir, or you have a threshold that where you want to transfuse the RBCs?
I think over the last many years, we have always been, even in other subset of patients, be it the myocardial infarction or patients with neuro critical care or the general intensive care, I think we have always gone with a threshold. And 7 seems to be fairly reasonable and a safe threshold.
Even in the trauma?
Trauma, I think most of the times we go by whether the patient is actively bleeding or not. That has been one of the major indications for our transfusion strategies. Instead of giving one number, probably again it depends upon what kind of trauma patients we see, whether they have coexisting background comorbidities or not. But by and large, between 7 to 8 seems to be fairly reasonable, and that is what we have been trying to do for a large number of patients with trauma. Joseph, your thoughts?
Yes. First of all, it appears to be a relevant question as to whether you should confine to a lower threshold transfusion strategy compared to a higher threshold in trauma patients. But of course, they ask this question based on the hemoglobin thresholds that we use in other disease processes. But then the situation of trauma is different, drastically different from any other stabler patient with, say, anemia that is not related to bleeding. The main difference in trauma is that when you have a patient who's bleeding, it's very difficult to tell how much loss there is within the first couple of hours. And hemoglobin may not be a very good target to aim for in this situation because there may be some effect of hemoconcentration. IV fluids may be running. And also the whole problem is to tell how much blood has been lost. And that's a very difficult question to answer in the first few hours of severe trauma. And the entire transfusion strategy would logically be based on how much blood is being lost. And in this case, of course, it's a very important question. And very importantly, the TRIC trial excluded patients who are actively bleeding. So that data is from patients who are not actively bleeding. And the whole problem, the reason why they excluded patients with active bleeding is purely because of this. It's difficult to tell how much blood is being lost. And if you clinically suspect bleeding, of course, you would top up with transfusions rather than wait for hemoglobin levels and go by the actual hemoglobin levels. And very often this target may be a moving target as well. Even though in this study, the authors say that they targeted a specific range of 7 to 9 versus 10 to 12, as did the TRIC study of 1999, they do not, in fact, tell us what methodology did they use for hemoglobin measurement, how often did they do it, how often is a very important question. How often do? You cannot do it practically every few minutes, isn't it? You may do it once in an hour, once in a couple of hours, but that may not be appropriate in trauma because a lot of blood may flow between two hemoglobin levels. So that's an important question which they haven't actually told us as to how often did they do and how did they titrate transfusion to reach a specific target range. they say they didn't aim for a threshold as such, but they aim for a target range. But as I mentioned, they don't tell us what is the methodology that they use. That's one of the problems. Then, of course, the initial inclusion is purely based on physician judgment as to whether the patient is acutely bleeding, or whether there is a suspicion only of acute bleeding, or whether there's a potential for acute bleeding. All this is highly subjective and may have been prone to error as well. We do not exactly know, the authors don't tell us how many of these patients were actually bleeding or no, that they don't tell us. Presumably, there may have been some patients whom they suspected to be bleeding who are in fact not bleeding. And later on, they may have been proved to be not bleeding, or on the other hand, they may not have been bleeding to the same extent as they expected to begin with. So that question is also unanswered. And then the question of sample size, of course, has been mentioned by Bharat. For a non-inferiority trial, the sample size may at times be actually larger than a trial that is meant to establish superiority. And in this case, in fact, I checked myself and I came to the same conclusion as they mentioned. You need more than 6,000 patients to prove non-inferiority. And they actually came up with a paltry 400 odd patients, which was grossly undersized to prove non-inferiority of this particular intervention. And then if you look at the actual number of patients that they screened and that they included in the trial, there were 1,045 patients who were screened, and out of this, 623 patients refused to participate in the study, about 60%. Rightly so, I feel, because they had their own doubts about whether this strategy is going to be appropriate or not. So a large number of patient families, in this case, probably refused to participate in the trial, which again makes it a confounder. They also found that within the first 6 hours, there was no difference in the number of units transfused or the cumulative volume of transfusion of red cells. I feel this is the most crucial period in a bleeding trauma patient within the first 6 hours. And if they really couldn't find a difference in the first 6 hours, then perhaps it may not be that relevant. And they also mention about hemostatic interventions in both groups, but they don't give details as to what sort of hemostatic interventions, which are very relevant, very important, I feel. The most important thing in trauma, in a bleeding trauma patient, would be to arrest the bleeding rather than top up with transfusions. So that question is also unanswered. And then, of course, in terms of the statistical modalities that they used, as I mentioned, they could not prove non-inferiority of a restrictive strategy, as Bharat mentioned, because the lower limit of the confidence interval had to be less than 0.68. Had to be more than 0.68. And in fact, it was below 0.68. And that's the reason why they could not establish non-inferiority. So at the end of the day, what they came up with, and besides, they expected a mortality of 25%. That was the expectation when they calculated the sample size. But the actual mortality was far less. It was in the range of 8 to 9%. 91% survival versus 92% survival, I think it was, between groups. So it was much, much lower than what they had expected. So that, again, will blow out their sample size calculation as well. So at the end of all that, as we rightly heard, it leaves us with this question unanswered as to which is a superior strategy. And one also doubts the relevance of the question. As I mentioned, in a bleeding situation, how much would you depend on the actual hemoglobin levels? Would you really go by hemoglobin levels done, say, every hour or couple of hours when you know your patient is bleeding, rather than transfuse with blood and blood products and look for a possible source and try to stop it expeditiously through an intervention. So these were my thoughts.
What do you practice, sir, in the trauma patients and non-trauma patients?
In an acutely bleeding trauma patient whom is suspected to be acutely bleeding, the general tendency wherever I practiced is to do a hemoglobin at whatever time is appropriate. And in many of the hospitals that we work, you either go by the blood gas hemoglobin level or the lab hemoglobin. Blood gas hemoglobin level may be instantly available, but the problem is it may be subject to calibration errors, not always reliable. And the lab reports, of course, wherever I have worked, by the time you get the report in an acutely bleeding patient, it will be largely irrelevant. A lot of blood would have been lost, and you have to rely on your clinical intuition as to how much blood loss there may be happening in terms of the hemodynamic status, blood pressure, heart rate, your ultrasound scan, CT scan, and so on. So measurement of hemoglobin levels in the real world, at least in our experience, has been of very poor useful utility in this particular situation. So you just go by your clinical intuition as well as the clinical parameters to decide upon how much may be an appropriate volume. And you generally do empirical calculation of how much you need to transfuse until you find the source and try to arrest the source. At least that has been the way we've practiced. And this study, I think on the whole, will not change that practice. In fact, as I mentioned, the TRIC trial also, they did not include patients who are actively bleeding purely for this reason.
I just want to add one point, sir. So unlike in the past, I think today we have with ultrasound coming into active use, by and large we are able to kind of estimate or know what's happening whether the patient is actively bleeding or not. Right? Previously, we used to run the patients back to CT scans, but I think to a large extent, most of us are not dependent on the ultrasound to see whether there is collections happening or not. And we are able to pick up bleeds much more earlier. So that way we can have some sort of an understanding as to whether the patient is actively, there's ongoing bleed or not in a majority of the cases.
I totally agree with you on that, Kansham. In fact, just yesterday, we had a patient who had blunt abdominal trauma. His initial CT scan, they said, showed minimal hemoperitoneum, and there was no active extravasation. There was some injury to the spleen. Then about 8 to 10 hours down the line, he spent a lot of time in the emergency department. By the time he came back to us, it was a little bit late. Took some 6 to 8 hours, I think. And when we did the scan, it was by no means minimal hemoperitoneum. There was plenty of perihepatic, perisplenic, pelvic blood. And we were not sure at that time whether the bleeding was coming from the spleen or whether from the pelvic fracture that he obviously had. So we took him down for a repeat CT scan, and that actually showed active extravasation from the spleen. And there was mesenteric ischemia as well on that repeat CT scan. So as you rightly mentioned, serial ultrasounds at timely intervals will definitely help you, not only in terms of bleeding, but also to detect, identify problems that may be related to, say, other injuries like pelvic fractures as well, and quantify the bleeding to some extent. You can redo the CT imaging as appropriate and direct your interventions accordingly.
Personally, your opinion on the crossover, sir, how does that impact the study?
In this case, because it was a cluster randomized trial, they used the strategy of restrictive in a particular hospital. Hospitals were randomized in a clustered fashion. So that hospital for a period of 1 year would do restrictive or liberal as they are assigned, and then washout period of 1 month, and they cross over. So that's the design of a cluster randomized trial anyway. So this kind of study, you can probably do it that way. That is an appropriate methodology. have no objections with that, rather than randomize patients to restrictive versus liberal strategy. Like, for instance, the study on out-of-hospital cardiac arrest, it's also done in a cluster randomized fashion because you adopt a policy for a period of time rather than allocate a policy to a particular patient. So that is an appropriate design in this particular situation, I feel.
So like if you have a patient whose hemoglobin is like less than 7 and you want to transfuse blood because there's ongoing bleed, would you transfuse it because is already ongoing bleed, or would you target around 9 and then transfuse? Like number of units.
I will keep transfusing. I wouldn't particularly worry about the absolute hemoglobin level. And if there is, as I mentioned, if there is ongoing bleed, the relevance of the hemoglobin itself, unless you have precise point of care measurement, becomes a little bit difficult to ascertain because lab hemoglobins will take their own time. You cannot depend on those to target, to titrate blood transfusion as such. And at least in our practice, the blood gas hemoglobin levels are not always reliable, and you may be grossly misled at times. So based on whether the patient is, if the patient is actively bleeding, you would keep transfusing and try to stop the bleeding by whatever intervention. It may be surgical or it may be angiography and embolization as soon as possible. That is actually the essential step. Transfusion is only a temporizing maneuver just to buy time. You need to specifically intervene and stop the bleeding. Otherwise, you will go into this cascade of blood loss, transfusion, and you get into this lethal triad that we all know about.
So we are going to transfuse only the RBC, sir, or you will do it even the FFPs and the platelets?
No, these days the practice is strongly towards replacement of RBCs as well as other blood products, including FFPs and platelets, definitely. Yes.
I just want to add one more point is that, again, with advancements in monitoring your coagulation status, today we have the tech which is available, or most of the labs are well versed in giving you the PT-INR, APTs much more frequently than what it used to be in the past. So, do you think we should still restrict to that 1:1:1, or based upon the coagulation abnormalities, if we can pick up based on the viscoelastographic studies, probably maybe we can kind of change our practice to much more specific product transfusions?
Maybe that's the way to go in the future. We don't have much experience with TEG in the acute trauma scenario, but it may be something that is worth studying. But otherwise, the coagulation parameters as such, again, there is a lag time by the time you draw the sample, get the reports, and how often do you do is the next question. So the more practicable, feasible methodology would be to try to go by a ratio. It may not always be possible, depending on the facilities that you have in your situation, the availability of blood products in your situation. But you try as much as possible to co-transfuse FFPs and platelets as well at an appropriate level to the best of the stocks that you have available in your situation.
How about a non-bleeding patient, sir, with a threshold or a target that you want to maintain?
Oh, in a patient who's not bleeding, there is strong evidence, of course, from the Restric Trial. In sepsis, we have a randomized control trial as well. In all those patients who have stable anemia, who are not bleeding, in most situations, as Ghanshyam mentioned previously, a threshold of 7 and a range of 7 to 9 would be more than adequate under most circumstances. In fact, there was the Restric Trial did not consider patients with ongoing ischemia or ischemic heart disease, but later on there have been studies in ischemic heart disease as well, saying that they tolerate lower thresholds as well. So for all we know, in the large majority of critically ill patients who are not actively bleeding, who have stable anemia, a cutoff, a threshold of 7 and a range of 7 to 9 is okay. And the cutoff of 10 grams percent, which was long considered to be the benchmark or the number to follow, has been by and large been disproven as we stand today.
As compared to the trick trial was actually enrolled patients after admitting into the ICU, sir. But
Yes.
this trial has considered patients right from the admission into the ED,
Yes.
emergency department. So is that the way we should probably go ahead with such kind of trials, especially in the trauma?
Yeah, of course, in trauma, because they come directly to the emergency department where the initial resuscitation does happen. And really, a bleeding patient should be handled in the emergency area as much as possible. And if there is ongoing active bleeding, ICU has very little to offer anyway. You need to stop the bleeding. Stopping the bleeding is of utmost priority, be it by a surgical procedure, say laparotomy, or be it angiography and embolization, which is becoming increasingly more commonly performed these days. So, in fact, my teachers used to say long years ago that ICU is no place to bleed. I still believe in it. We don't have much to offer, apart from keeping on transfusion after transfusion, which in the long run will lead to a cascade of problems rather than solving them. The onus should be on to stop the bleeding, not to keep on transfusing. That doesn't help in acutely bleeding patients. So emergency or operating room, one or the other, or radiography suite, one or the other.
Sir, are you using TEG, sir, Ghanshyam, sir?
Not routinely. We recently had one patient, which is a very peculiar patient. This guy had upper GI bleed. Endoscopically tried at a different place. They could not kind of secure the bleeding. Then they again went in endoscopically one more time, put clips there. They could not. Then was taken up for surgery. Initially kind of temporized. Then again he started bleeding. So he was then transferred to our unit. He was stable. Then again he started to bleed. He was taken up for surgery. The tissues were very fragile. They couldn't identify a bleeder. So the surgeons kind of whatever they could kind of they created a gastrostomy and they kept the wound open, right? Because the first place where they had kind of sutured the wounds, he was going into a burst abdomen. And once in a while, he used to continuously bleed from the open side. So that's when we used the TEG. And that's when, because his platelet counts, PTA and everything was normal. So we used a TEG which suggested that probably we had to give him some cryoprespirates. Subsequently, when we went back to the family and we started probing them, the history that was given was he had some kind of a bleeding diathesis. Even as a child, whenever he used to get injured, he would just bleed. But they could never kind of evaluate or kind of, actually did any investigation as to what was the reason for bleeding. So once in a while, I'm using it now, not routinely. I was not using it in the past, but now I think
that could be the probably next way of looking at things, how to transfuse and when to transfuse based on the lab values. Probably it's more quicker compared to the regular PTINR and hemoglobin values.
I think you get it in 20, 30 minutes, isn't it?
Yes, sir. You'll get it immediately. And, it gives you a clear idea about where the coagulation abnormality is there. And probably based on that, you may be able to pick up what kind of products you want to transfuse.
Yes.
Did that cryos help the patient as such?
Temporarily, yes. Right. He bled again, so they had to take him again. There was a spurter. This time they identified a spurter. Luckily, he was discharged home. He had long stay in the ICU, multiple transfusions. He's under the follow-up of a hematologist, so we just wanted to work up the reason, what could have been the possible reason, or he might be having some kind of a hemophilia. That's what we kind of concluded, either some kind of a hemophilia or some kind of a disease where von Willebrand's factor could be deficient. We were not able to, kind of identify it at that point of time.
Sir,
So
any situations where we have a place for the liberal transfusion strategy in the current scenarios in the critical care?
Liberal strategy, there are questions about the restrictive strategy in several clinical situations. First, as I mentioned, is in patients who have active acute myocardial ischemia, ongoing myocardial ischemia. That question is still not satisfactorily answered. You would hesitate to drop the hemoglobin to very low levels in that situation. And these are patients who might possibly benefit from a slightly higher threshold. And second, of course, in neurosurgical practice specifically, there have been some observational data to suggest that a higher threshold may be more appropriate. This again has not been proven or studied in a randomized controlled fashion. That's another area which needs to be further investigated. These are often a couple of situations in which you might change your thresholds from a lower to a slightly higher level. But as I mentioned, the subgroup analysis of all this in the TRIC trial and subsequent trials as well says, as far as we know, by and large, 7 to 9 is appropriate in most patients.
Your closing remarks of this Restric trial, sir?
I wouldn't have much to gain from this particular study. The question itself is a relevant question, but the way they conducted this was actually not very methodically done. Several holes in it. First of all, the sample size was far short of what they should have had. How did they target or titrate the number of units transfused? How often did they do hemoglobin levels? What levels did they go by? Not very clear. What were the interventions that they used? Not clear. The actual mortality was far less than what they considered at the beginning. So at the end of the day, they could not prove non-inferiority either. So to me, this trial doesn't add much to the body of knowledge that we already have. And it wouldn't change my practice either. I would continue to transfuse patients whom I suspect are continuing to bleed actively. I will continue to transfuse them until I can stop the bleeding, which I would again underline, that is priority. Until such time as you can stop the bleeding, you would transfuse with blood and blood products if it's a sufficiently large bleed, rather than go by crystalloids and other substitutes, which should only add to the hemodilution, dilution of the coagulation factors, and result in probably more bleeding. So this study doesn't add much to the knowledge pool that we have, nor would it change practice in any major way, as far as I can see it.
Thank you, sir.
Sir, before we close, sir, just your thoughts on two subset of patients where, maybe a liberal strategy would be kind of thought of. One is a pregnant patient who is admitted to the ICU for some other reason, right? Do you think we should keep them slightly on the higher side? Not sure about what's happening with the fetus. So maybe that is one subset of patients probably we may think of slightly keeping it on the higher side of the hemoglobin.
Yeah, what you're saying is probably true. Perhaps you would aim for a slightly higher range. You can maybe keep the range between 7 to 9. I find that it's important to underline it's not an absolute number of 7. It is not like you aim for this magic number of 7 and stop there. And pregnant patients may be a subgroup who hasn't really been investigated at depth to see. More studies of transfusion thresholds exclude pregnancies anyway. So that is one of the situations in which you may aim for a higher threshold. And as we know, it might adversely affect the fetus if the oxygen delivery is compromised. At least that's the physiology. So perhaps there is a reason to aim for a higher level in pregnant women, as you rightly point out.
Like 10 to 12, sir, or 9 would be sufficient?
That question is difficult to answer. More than 10, I think, would be a little bit overboard, because many pregnant women, particularly in our scenario, have some level of anemia. And if you target more than 10, you might end up giving them far more transfusions than they actually need.
No, thank you. So, Ghanshyam sir, your thoughts and take-home message from this trial?
I don't think I have anything much to add, Navina. Jose sir and Bharat have kind of given complete overview of the Restric Trial. Just to all my listeners, I would one point that I would suggest is, if you can, please read the book authored by Dr. Jose, which is Controversies in Critical Care. One of the most well-written books in recent times, where different topics have been very beautifully written in a simple language, taking into consideration all the trials, all the evidence which was there till that point of time. I think it's a fantastic book, and I think it's one of those books which each one of us should have. So if you can, please get a copy of that book. It's extremely well written and very useful book. Controversies in Critical Care.
Yeah, it's readily available from Amazon, and the price is also being reduced in the last few weeks. And we've tried our best to keep the evidence updated at the time of writing as much as possible, including all the main studies that address the topic in question. It essentially involves all the controversial topics that you come across in day-to-day practice, questions that are difficult to answer by the bedside. So this particular book aims to arrive at logical conclusions based on the pool of evidence that we have. So if you're interested, you would certainly be most welcome to go through it.
Thank you, sir. I request everyone to subscribe to the Higgs YouTube channel so that you can get the alerts and also the other old videos that are there, so that you can go back to them and refer to them. Thank you, Joe sir, for sharing your wisdom. Thank you, Ghanshyam sir. Thank you, Bharat. We'll meet next month.
Thanks, Navina. Thanks, Ghanshyam, Bharat. Thanks, everyone else.
Thank you, everyone.